If you don't know liver segments, you cannot operate on the liver.
That's a pretty definitive statement. There's not a lot of wiggle room there, is there?
None at all. It feels like something that, a very stern surgical professor would scrawl on a whiteboard on day one, just staring down the entire class.
Yeah, it's got that "you shall not pass" vibe to it.
It really does. But I get the sense from the material we've been looking at that it's not just about being tough or, gatekeeping the profession.
No, not at all. It's not ego. It's a survival rule. It's brutally simple. If you don't know the map of the territory you're about to enter, you are going to get lost. And in liver surgery, getting lost means the patient bleeds out on the table.
Well, that certainly sets the stakes for today's deep dive. Welcome, everyone. Today we are tackling the liver. And not in that sort of high school biology way, this big organ that just filters stuff. We're looking at it through a surgeon's eyes as this incredibly complex territory that requires a very specific and, as you said, very high-stakes map.
Exactly. We're sort of treating this as an anatomy to trauma guide. The whole point is to bridge that gap between the neat color-coded diagrams you see in a textbook.
Right, where everything is perfect.
Everything's perfect, and the absolute chaos of an operating theater where everything is red and wet and moving.
I love that phrase, anatomy to trauma.
Right.
Because it feels like two completely different worlds, doesn't it?
Yeah.
You have the elective surgeon who's meticulously planning a tumor resection for weeks.
They're drinking their coffee, looking at the scans, measuring angles.
Exactly. And then you have the trauma surgeon, 3 in the morning in the ER, with a car crash victim who is actively dying in front of them.
And the incredible thing, the thing that ties it all together, is that they are both using the exact same map. One is using it to carefully deconstruct the organ piece by piece. The other is using it desperately, trying to figure out how to just hold it all together.
Okay, so here's the roadmap for you listening today. We have a lot of ground to cover. We're going to start by uncovering this hidden map of the liver, the Couinaud classification. Then we're going to bust what seems to be a huge myth about the liver's midline, something that apparently trips up surgeons all the time.
The fake landmark versus the true anatomy. Yeah, that's a really critical point.
Right. From there, we'll get into what we're calling surgical math. Basically, how much liver can you actually remove and still have the patient survive?
The safety margins.
And then we're going to shift gears completely. We're diving into the chaos of the trauma bay. We'll talk about something called the lethal triad, which sounds absolutely chilling.
It is.
And we'll cover the specific hands-on maneuvers that surgeons use to quite literally buy time when a patient is bleeding to death.
It's a journey, really, from this elegant architecture to just pure crisis management.
So let's start with that architecture, this hidden map. When I just picture a liver, I see a big reddish-brown wedge, a big right side, a smaller left side. It seems like one solid thing.
That's what everyone thought for a long time. And surgeons were, frankly, terrified of it. They called it a vascular sponge. The moment you cut into it, it just bled from everywhere, and there seemed to be no logic to it.
So what changed? Who figured it out?
A French surgeon named Claude Couinaud, he's really the father of all of this. What he did was he stopped looking at the surface of the organ.
Okay.
He started looking at the plumbing inside. He would do these things called corrosion casts. He'd inject a liquid plastic into the veins of a cadaver liver, then use acid to melt away all the soft tissue.
Wow.
And what he was left with was this perfect three-dimensional tree of all the blood vessels. And that's when he realized it's not one big sponge, and it's not even just 2 lobes. It's actually divided into 8 distinct segments.
8 segments. And the key phrase I keep seeing in the source material is functionally independent. That sounds really important. What does independent actually mean here?
It means the liver is built to be modular. I think the best analogy is to stop thinking of it as one giant mansion and start thinking of it as a row of 8 townhouses.
Okay, a row of townhouses. I like that.
In a mansion, if the main water line bursts in the basement, the entire house floods, right? If the main circuit breaker blows, the whole house is dark, everything is interconnected.
It's the old way of thinking, the vascular sponge idea.
Exactly. But Couinaud showed us it's actually these townhouses. Each segment, each townhouse has its own separate utilities. It has its own water pipe coming in, which is its branch of the portal vein and the hepatic artery.
So that's the inflow.
That's the inflow. And just as crucially, it has its own sewer pipe going out, its own bile duct, and its own drainage, a vein sending blood back towards the heart.
So if I'm getting this right, segment number 3 is its own little self-contained unit. It doesn't rely on segment 4 for its power or its plumbing.
You've got it. It is a completely self-sufficient island. And that is the absolute cornerstone of modern liver surgery. Because if you have a tumor that's only inside townhouse number 3,
You can just disconnect the pipes to number 3?
you can disconnect the pipes, you can cut along the property lines, and you can remove that entire townhouse without damaging the structure or function of number 2 or number 4 next door.
That makes so much sense. Before they knew this, they must have been just cutting across property lines randomly.
They were. They were crashing through the living room walls of the neighboring segments, hitting shared plumbing and causing these massive, uncontrollable bleeds. Once you see the segments, you can perform a resection, you can cut along the lines.
Which brings us back to that first quote. If you don't know the segments, you can't operate.
You're flying blind.
Okay, so we have these 8 townhouses. The problem is when you open up a patient's abdomen, there aren't little numbers painted on the organ. It still looks like one solid piece. So how do you visualize the boundaries? The notes mention vertical knife cuts.
This is the mental model a surgeon has to build. So imagine you're looking down at the liver in a patient. Now you have to imagine 3 massive invisible knives oriented vertically. These knives correspond to the 3 major hepatic veins.
The hepatic veins, so these are the big outflow pipes for the whole organ.
That's right. They're the major drainage system. So the first knife is the right hepatic vein. Imagine slicing from top to bottom through the big right lobe. This cut acts as a wall, and it separates the right liver into an anterior sector, which is the front part,
Okay.
and a posterior sector, which is the back part.
So now the right side is split into a front half and a back half.
Correct. Your second knife is the left hepatic vein. It does a similar job, slicing the left lobe. But the most important one, the one that causes all the confusion, is the knife in the middle hepatic vein.
Why is the middle one the VIP?
Because the plane of the middle hepatic vein marks the true functional midline of the liver.
Okay, I want to pause on that because this is where the outline gets really interesting. It calls this section the myth of the midline. And it says this is the most tested distinction. Why is something as basic as finding the middle of an organ so tricky?
It's tricky because the body plays a trick on you. It gives you a decoy. When you open an abdomen and you look at the liver for the first time, there is a very obvious white fibrous ligament that runs right down the front.
I think I've seen this in diagrams. The falciform ligament?
That's the one, the falciform ligament. And visually, it looks exactly like a dividing line. It's sitting right there on the surface, and it practically screams, hey, I am the border. The left lobe is to my left, the right lobe is to my right.
It's the obvious visual center.
It is the obvious visual center, and it is a complete lie.
A lie.
An anatomical decoy. This is one of those things you just have to burn into your brain. The mnemonic is falciform is fake.
Falciform is fake. Okay, why? What makes it fake?
Because it has absolutely nothing to do with the internal plumbing, with those townhouses we just talked about. The falciform is just a surface attachment. It tethers the liver to the abdominal wall. Functionally, it actually sits well inside the true left liver.
So if a surgeon assumed that was the midline and cut along it,
they'd be making a huge error. They'd be slicing deep into functional left lobe tissue, hitting blood vessels and bile ducts that they have no business being near if they think they're on the border.
Okay, so if the falciform's the decoy, where's the real border? What's the true midline?
It's called Cantley's line.
Cantley's line. Can you see it on the surface?
No, it's an imaginary plane, which is why it's tricky. But you can map it out by connecting 2 specific landmarks. This is what surgeons do. First, they find the gallbladder fossa. That's the little hollow on the underside of the liver where the gallbladder snuggles in.
Okay, landmark 1, gallbladder.
Then they look deep in the abdomen for the inferior vena cava, or IVC, which is the huge vein running up the back. You draw an imaginary line from the gallbladder fossa straight up to the IVC.
Gallbladder to IVC.
That line, that plane, runs directly on top of the middle hepatic vein we talked about, and that is the true functional watershed. Everything to the left of Cantley's line is functionally left liver. Everything to the right is functionally right.
So the mantra is falciform is fake, Cantley is correct.
That's the one. And it's so important because if you get it wrong, you miscalculate everything. You might think you're about to do a right hepatectomy, but if you cut along the falciform, you're leaving a huge chunk of the right liver behind and accidentally taking a piece of the left.
Which would throw your surgical math off completely.
It would be a disaster for planning a safe resection.
Okay, this is making sense. So we've established the real borders.
Yeah.
We have our townhouses. Now we need the street numbers. The source material says there's a logic to this, sort of a clockwise pattern. But first, there's an outlier. Segment 1.
Ah, yes, segment 1, the caudate lobe. The caudate is, it's the hermit of the liver.
The hermit.
It lives alone. It's tucked way in the back behind all the other segments, and it sort of wraps itself around the inferior vena cava. It doesn't really play by the left versus right rules.
Is it just the location that makes it an outlier?
It's the plumbing again. Remember how we said the other 7 segments drain their blood into those 3 main hepatic veins?
Right, the 3 nice cuts.
Well, segment 1 is special. It has its own private drainage system. It has several tiny little veins that drain directly into the vena cava. It bypasses the main system entirely.
It has its own private exit onto the highway.
Exactly, which surgically makes it very treacherous to remove. You're operating right on the wall of the biggest vein in the entire body.
Got it. So that's segment 1, the hermit in the back. Now for the rest of them, 2 through 8. How do we navigate this clock?
Okay, so you're looking at the liver from the front, from the patient's feet looking up. We start on the patient's left side, and the simple rule is left equals small numbers. So besides the caudate, the left lobe is made up of segments 2, 3, and 4.
Walk me through the positions.
We start way out on the far upper left, that's segment 2. Then you drop straight down the far lower left, that's segment 3.
Okay. 2 on top, 3 on the bottom.
Then you move back towards the middle into the area around that fake falciform ligament. That whole section is segment 4, and it's often split into a top part, 4A, and a bottom part, 4B.
So 2, 3, and 4. That makes up the entire functional left liver.
You've got it. Now, we cross Cantley's line, we're in the right liver, and the rule here is right equals big numbers. So we're dealing with 5, 6, 7, and 8, and we're going to move in a clockwise spiral.
Clockwise. Okay, we just finished with 4 in the middle. Where is number 5?
Segment 5 is right across the line from 4B. It's at the bottom and it's in the front, so we call it anterior-inferior.
Got it.
Then you move clockwise to the far right edge. That's segment 6. It's at the bottom, but it's in the back. Posterior-inferior.
Okay, so 5 front, 6 back.
Then we spiral up to the top right corner. That's segment 7. It's on top and it's in the back. Posterior-superior.
And to finish a loop.
We come back towards the midline at the top. Segment 8. It's on top and it's in the front. Anterior-superior.
So it's a full circle. 5, 6, 7, 8.
It is. And there's a really good mnemonic in the notes to help you visualize this in 3D because the liver is a thick organ, not a flat map. The mnemonic is 5 and 8 face front, 6 and 7 sit back.
5, 8 face front, 6, 7 sit back. Say more about that.
It means that when a surgeon first opens the abdomen, the parts of the right lobe they can actually see are segment 5 on the bottom and segment 8 on the top.
Ah, okay.
Segments 6 and 7 are hidden. They're tucked behind, deep against the back of the abdominal cavity. You often can't even see them until you physically lift and rotate the entire right lobe of the liver forward.
That helps a lot. It's like 5 and 8 are the front porch, and 6 and 7 are the back bedrooms you can't see from the street.
That's a great way of thinking about it.
So we have the map, we have the numbers. Let's put this into practice. Let's talk about the surgical math, because I think people hear hepatectomy and just think you're yanking out half the liver. But it's way more precise than that.
Oh, it's incredibly precise. Surgeons speak in this code.
Yeah.
When someone says, I'm performing a standard right hepatectomy, what they mean specifically is, I am removing segments 5, 6, 7, and 8. They are cutting along Cantley's line and taking everything to the right of it.
And a left hepatectomy, by the same logic,
is removing segments 2, 3, and 4.
Now, I saw a term in the notes that caught my eye. Extended right hepatectomy? That sounds pretty aggressive.
It is a massive operation. It's also called a right trisegmentectomy, which is a bit of a misnomer. What it means is that you are taking the entire right liver 5, 6, 7, and 8, and you are also crossing Cantley's line to take segment 4 from the left side.
Whoa. So you're basically taking everything to the right of that fake falciform ligament.
That's pretty much what it works out to, yeah. You are leaving the patient with only segments 2 and 3, just that small, far left portion of the liver.
Which begs the question, can a person actually survive with just those 2 little segments? How much liver do you need?
This is where we get into the safety margins, and this is where the liver becomes, it's basically a magical organ. It's the only internal organ in the human body that can truly regenerate.
Like a starfish cutting off an arm.
Exactly like a starfish, or, like the myth of Prometheus.
Right, the eagle comes and eats his liver every day, and it grows back every night.
The ancient Greeks were onto something. They knew this organ had this incredible ability to return. And it's true. If you have a healthy, normal liver, you can remove up to 75% of it.
You only need to leave 25%.
You need a 25% future liver remnant is the term. If you leave that seed, The liver cells, the hepatocytes, they sense the deficit. They start dividing like crazy, and the organ will grow back to almost its original size in just a matter of weeks.
That is absolutely mind-blowing.
It is, but, and this is probably the most important, but in all of liver surgery, that math only works if the remnant liver is healthy.
And what if it's not? What if the patient has cirrhosis?
Then it's a whole different ballgame. If the patient has a diseased liver, from alcohol, from hepatitis, from fatty liver disease, that regenerative engine is weak. It's rusty.
So the 25% rule is out the window.
Completely. For a cirrhotic liver, the consensus is you need to leave at least 40% behind, maybe even more if you miscalculate. If you treat a cirrhotic liver like a healthy one and take too much, the patient develops something called small for size syndrome.
That sounds bad.
It's fatal. The tiny, sick piece of liver you left behind gets overwhelmed. All the blood flow that was meant for a whole organ is now being forced through this little remnant. It can't handle the pressure. It swells. It fails. The patient turns yellow, and they die from acute liver failure.
So the surgical math isn't just geometry. It's a quality assessment. You have to know the health of the tissue before you can decide how much you can safely take.
Exactly. This is all done with advanced imaging and volume calculations on a computer long before a scalpel ever touches the skin.
Okay, that whole world is the world of elective planned surgery. You have maps, you have calculators, you have time. I want to pivot now, just like the outline says. Shift in tone. We're leaving that calm, planned environment, and we are walking into the trauma bay.
Yeah, this is a completely different sport. In elective surgery, anatomy is king. In trauma, physiology is king. You don't have time for elegant dissections. You have a patient who's been in a car wreck, they're bleeding, and the only question that matters is this person going to die in the next 5 minutes?
It's just pure crisis management. And to manage a crisis, you need a quick way to classify the damage, a shorthand. And that's this AAST grading system.
Right. The American Association for the Surgery of Trauma, they created this universal language for organ injury. For the liver, it runs from grade 1 up to grade 6.
Let's just quickly run through them so people get the scale. Grades 1 and 2.
Those are considered minor. A grade 1 might just be a bruise under the capsule of the liver. A grade 2 is a tear, a laceration, but it's shallow, less than 3 centimeters deep.
And grade 3.
Grade 3 is a deeper tear, over 3 centimeters. But the key for these first 3 grades is that they typically don't involve the huge central blood vessels.
Then we get to the big ones, grades 4 and 5.
Now you're in major injury territory. Grade 4 is a massive disruption of the liver tissue, maybe a whole lobe is pulped. And grade 5. Grade 5 is the nightmare scenario. That means an injury to the major hepatic veins or the retrohepatic vena cava itself, the main outflow pipes.
And what's a grade 6?
Grade 6 is a hepatic avulsion. That means the liver has been completely ripped off its vascular attachments. It's essentially floating free in the abdomen. That is, for all intents and purposes, an unsurvivable injury.
Okay. Now here's the part in the research that really genuinely surprised me. My assumption was that if you have, say, a grade 2 or grade 3 liver tear, the surgeon's job is to rush you to the OR and sew it up.
That's the logical assumption, and that's what we used to do 30 or 40 years ago. And we inadvertently killed a lot of people.
Really? How?
Because we learned a very hard lesson, and the statistic in the notes is staggering. For blunt trauma, grades 1 to 3, the success rate of what we call non-operative management, or NOM, is 80 to 90%.
Non-operative management, you mean? Doing nothing.
Doing nothing invasive. And here's why. The liver is like a wet sponge.
A wet sponge.
Imagine taking a soaking wet kitchen sponge and trying to stitch it together with a needle and thread. What's going to happen?
The thread is just going to pull right through. It'll tear the sponge even more.
Precisely. The liver tissue is what we call friable. If you go in there and try to put sutures in a minor tear, your needle and thread will just rip the tissue further and cause more bleeding than the original injury.
You actually make it worse.
You make it much worse. And there's a second reason. Think about physics. If the liver is bleeding inside a closed abdomen, the blood builds up, the pressure inside the belly rises, and that pressure actually pushes back on the liver. It creates a natural tamponade.
Like putting your thumb over the end of a bleeding hose.
It's the body's own damage control. But if you rush that patient to surgery and make a big incision down their belly, you release all that pressure, you've just popped the cork, and a bleed that might have been slowing down on its own is suddenly a gusher again.
So in many cases, the best course of action is to just wait.
It's to wait. But, and this is the most important but in all of trauma surgery, this only applies if the patient is hemodynamically stable.
We hear that term on medical shows all the time. Vitals are stable. What does that actually mean for the decision-making process?
Stable means their physiology is holding up, their blood pressure is acceptable, their heart rate isn't 150, their brain is getting enough oxygen, they are not actively circling the drain. If a patient is stable, the rule is you do not operate. You take them to the CT scanner.
And what are you looking for on that CT scan?
You're looking for something called an arterial blush.
A blush.
Yeah. You inject intravenous contrast dye. If there's active, high-pressure bleeding from an artery inside the liver, you'll see a bright white cloud of that dye spreading out from the vessel. That's the blush. It means active extravasation.
And if you see the blush, then you operate.
Still no. This is where modern medicine is so incredible. If you see a blush in a stable patient, you call an interventional radiologist. They don't cut the patient open. They go through a tiny needle, poke in the groin, thread a catheter all the way up into the hepatic artery, find the exact little branch that's bleeding, and plug it.
Plug it with what?
Tiny metal coils, or a type of biological glue. They essentially cause a targeted blood clot right at the source of the leak, all from the inside.
So no big incision. You don't lose that tamponade effect.
It's an incredibly elegant solution.
Okay. That's the stable patient pathway. That's the modern success story. Now let's go to the dark side, the patient who is unstable.
Unstable means they are crashing. Their blood pressure is in the tank, maybe 70/40. Their heart rate is screaming. They're pale, they're cold, they are dying.
There's no time for a CT scan.
The CT scanner becomes the tunnel of death for an unstable patient. You can't waste that time. They go straight from the ER to the operating room.
This is where we get into that crisis management section.
Yeah.
The notes have this heading, the lethal triad. And I get the feeling this isn't just a scary name.
No, it's a physiological reality. It's a death spiral. If you understand the lethal triad, you understand why trauma patients die. The mnemonic to remember is HAC. HAC.
Okay, let's break down HAC. What's the H?
H is hypothermia. The patient gets cold.
Why do they get cold?
A few reasons. 1, blood is warm. When you're bleeding out, you're losing your core heating fluid. 2, we give them room temperature IV fluids. 3, the OR is cold, and their entire abdominal cavity is now open to the air. Their temperature plummets.
Okay, so they're cold. What's the A?
A is acidosis. This is a chemistry problem. Because they're not getting enough oxygenated blood to their tissues, their cells switch to an emergency backup fuel called anaerobic metabolism. The waste product of that process is lactic acid. The acid builds up in the blood, and the body's pH drops.
And the C.
C is coagulopathy, and this is the one that kills you. Coagulopathy means the blood loses its ability to form clots. And here's how it all connects. The enzymes and proteins in your blood that are responsible for the clotting cascade. They're like Goldilocks enzymes.
Goldilocks.
They only work if the conditions are just right. They require a normal body temperature, around 37 degrees Celsius, and a neutral pH. If the patient gets cold from hypothermia and their blood gets acidic from acidosis, the clotting factors just start working. They physically change shape and become useless.
I see the feedback loop. It's a spiral.
It is a vicious, vicious cycle. The colder and more acidic they get, the less they can clot. The less they clot, the more they bleed. The more they bleed, the colder and more acidic they get.
And the notes say that once this triad gets going, the mortality rate just skyrockets.
It becomes almost impossible to recover from because traditional surgery stops working. You can put a perfect stitch in a bleeding vessel, but the blood itself is so thin and unable to clot that it just oozes right through the needle holes. It's like trying to sew water.
So what can you possibly do? If sewing doesn't work, how do you stop the bleeding?
You have to change your entire philosophy. You stop being a meticulous surgeon and you become a damage controller. You shift to a strategy called damage control surgery.
What's the principle behind that?
The principle is physiology before anatomy. You abandon any attempt at an elegant, definitive repair. Your goals become brutally simple, the ABCs of damage control. A, arrest hemorrhage. Stop the bleeding by any means necessary, not with fine sutures.
Yeah.
You take huge packs, huge surgical sponges, and you literally stuff them into the abdomen around the liver, physically packing the wound to create pressure.
Just brute force tamponade.
Brute force.
Yeah.
B, control bowel contamination. If there's also a hole in the intestine, you don't spend an hour sewing it back together. You just staple both ends of the hole shut and move on. Stop the source of infection.
Big C.
C, close temporarily. You don't even close the patient's skin. You can't because of all the packs and swelling. You just put a plastic bag or a vacuum dressing over the open wound.
You leave their abdomen open.
You do. It looks barbaric. But the #1 goal is to get out of the operating room, usually in under an hour, because the OR is where they're getting colder and more acidotic.
So where do you take them?
You take them to the intensive care unit. The ICU is where you actually save their life. You warm them up. You correct the acidosis with medications. You give them massive transfusions of blood, plasma, and platelets to fix a coagulopathy. You focus entirely on breaking the lethal triad.
And only then?
Only then, maybe 24, 48 hours later, when the patient is warm, their blood chemistry is normal, and they can actually form a clot. Do you take them back to the OR for the definitive operation to remove the packs and properly fix the liver?
That's just an incredible shift in thinking, admitting that the surgery itself can be part of the problem.
It's one of the biggest advances in trauma care in the last 50 years.
I want to zoom in on one specific technique from that initial chaotic surgery. The belly is open, blood is everywhere. The notes talk about a classic high-yield maneuver called the Pringle maneuver.
Ah, yes, the Pringle, named after James Hogarth Pringle from way back in 1908. This is often the very first thing a surgeon does when they open an abdomen and find a shattered liver.
Describe it. What are you physically doing?
You take your hand, you slide it behind a structure called the hepatoduodenal ligament, and you pinch it between your thumb and forefinger. Or you put a big vascular clamp across it.
The hepatoduodenal ligament. What's inside that structure that makes pinching it so powerful?
It contains the portal triad. This is the main inflow pipeline to the entire liver. The mnemonic is HAB, H for hepatic artery, A for always the portal vein, and B for the bile duct.
So by clamping that one stalk of tissue, you're literally turning off the faucet to the liver.
That's exactly what you're doing. You are stopping all inflow from both the hepatic artery and the portal vein. And in most cases, the torrential bleeding from the liver will stop, or at least slow down to a manageable ooze.
And that tells you the injury is somewhere in the liver tissue itself or in those inflow vessels.
Right. It gives you a moment to breathe, to see, and to figure out a plan. But there's a scenario where it doesn't work.
What happens then?
That is the moment your stomach just drops through the floor.
You've clamped the Pringle, the inflow is off.
And dark venous blood continues to well up from behind and around the liver, flooding the whole field. If you have the Pringle on and the liver is still bleeding massively, it tells you one thing. The bleeding is not from the inflow. It's from the outflow.
It's coming from the hepatic veins or the vena cava itself.
Correct. A retrohepatic IVC injury. This is a classic grade 5 injury. And the Pringle doesn't work because the blood is coming from the biggest vein in the body, which is behind the liver, and backwashing into the wound.
And why is that so much more lethal? The mortality is 50 to 80%.
Because of access. The retrohepatic vena cava is, by definition, behind the liver. To see it and sew the hole, you have to lift the liver out of the way. But the very act of moving the liver often rips the hole in the vein even wider. It's a catch-22 from hell.
Is there anything you can do? Is there any move left in the playbook?
There is one last-ditch Hail Mary procedure. It's famous, it's tested on all the exams, but it's very rarely performed because it's so difficult. It's called an atriocaval shunt.
Atriocaval shunt, how does that work?
You essentially bypass the entire problem area. You have to open the chest, put a large tube into the right atrium of the heart, and thread it down inside the vena cava all the way past the liver.
You're putting a pipe inside the bigger pipe.
Exactly. You're creating a tunnel. The blood from the lower body flows through your shunt tube, bypassing the torn section of vein behind the liver. This isolates the injury, it creates a dry field, and it gives you a slim chance to actually see the hole and repair it.
That just sounds almost unbelievable that it's possible.
It's the very definition of heroic surgery.
Okay, let's step back from that brink. Let's say the Pringle worked, the packing worked. The patients survived the OR, they survived the ICU, they're recovering. But the danger isn't over. The notes call this section the aftermath, and it lists several delayed complications.
That's right. You've won the war, but now you have to clean up the battlefield. The single most common delayed problem after a major liver injury is a bile leak.
Which makes sense. If the liver tissue was crushed, the little bile ducts inside it were crushed too.
Exactly, and bile is very irritating. If it leaks into the abdomen, it can cause pain and infection. But the good news is we rarely have to operate again for this. We can usually manage it with a procedure called ERCP.
That's with a scope, right?
Yes. A gastroenterologist passes a scope down the throat into the small intestine, and they can find the opening of the bile duct. They can then thread a tiny plastic tube, a stent, up into the duct, past the leak. It's like putting a liner inside a leaky pipe to allow it to heal around it.
And what about this other term, hemobilia?
Hemo for blood, bilia for bile. This is a strange one. It happens when an injured artery inside the liver heals by forming a fistula, an abnormal connection directly to an injured bile duct.
So the patient is bleeding from an artery, but the blood is going into their biliary system.
Exactly. And there's a classic triad of symptoms for this. It's called Quint's triad. A good mnemonic is PJB.
PJB.
P is for pain, usually in the right upper part of the abdomen. J is for jaundice, the blood clots in the bile ducts blocking them up so the patient turns yellow. And B is for bleeding, specifically gastrointestinal bleeding. The blood flows down the bile duct into the intestines, so they might vomit blood or have black tarry stools.
Pain, jaundice, and GI bleeding.
If you see that combination days or weeks after a liver trauma, you have to think of hemobilia. And the treatment, again, is not surgery. It's that same angioembolization technique. The radiologist goes in and plugs the specific artery that's causing the problem.
And the last one listed is a liver abscess.
Which is really just an infected hematoma, a collection of old blood that gets seeded with bacteria. The treatment is usually draining it with a needle and giving strong antibiotics.
We have covered such a huge range of material today. I mean, from the beautiful clean geometry of the Couinaud segments to the absolute carnage of a grade 5 injury and the lethal triad.
It really does show the two faces of the liver, doesn't it?
Yeah.
On one hand, it's this incredibly precise, elegant machine with 8 independent modules. And on the other hand, it's this fragile, bloody organ that can kill you in minutes.
So let's try and wrap this up for the listener. What are the absolute key takeaways you need to file away from this deep dive?
I think number 1 is the map itself. Know that the liver is 8 segments, and that map is defined by the hepatic veins, those vertical knife cuts.
And number 2 has to be the midline.
Absolutely. Do not be fooled by the falciform ligament. Falciform is fake, Cantley is correct. The true line runs from the gallbladder to the IVC. That's non-negotiable.
Now on the trauma side.
On the trauma side, it's physiology over anatomy. You have to respect the lethal triad: hypothermia, acidosis, coagulopathy. If that spiral starts, you get out. You switch to damage control, and you use the Pringle maneuver. Pinch the inflow. If the bleeding stops, you have a fighting chance. If it doesn't, you have to suspect the worst, the vena cava.
And it all just keeps coming back to anatomy, doesn't it? Knowing Cantley's line tells you how to plan a resection. Knowing where the hepatic veins are tells you why the Pringle maneuver might fail.
If you don't know liver segments, you cannot operate on the liver. We started there, and after going through all this, I think it's impossible to argue with that statement.
I want to leave our listeners with one final thought to mull over. We've talked about how vulnerable the liver is, how quickly it can kill you, but we also talked about its resilience, that you can cut it down to just 25% of its size, and it will grow back.
It's the only organ that does that. It's almost mythical. The Prometheus story. The ancients knew there was something profoundly special, something unique about its ability to recover.
It's this strange paradox. It's an organ that absolutely demands respect for both its incredible strength and its profound fragility. And the difference between the two really does seem to come down to whether or not you have the right map.
Well said. Stay curious.
See you next time on The Deep Dive.